Welcome back, and yes, this one's a long, deep dive episode. Today we're answering a deceptively simple question that matters to millions of runners, walkers, and anyone who spends a lot of time on their feet. Can regular running prevent chronic venous insufficiency, or could it actually make problematic leg veins worse? We'll go right through the science, the myths, the real physiology of your veins, patient stories, what the best evidence actually shows, practical tips you can use after the video, and when you should absolutely see a specialist. By then you'll know what to do on your next run, so your legs stay happy for decades. Alright, let's begin. It starts with a scene most of us know. You lace up, hit the pavement, your heart pumps, your calves thump, and you feel alive, but underneath the skin, tiny one-way valves in the veins are working overtime to push blood back to your heart against gravity. When those valves fail or the calf pump stops working well, blood pools in the legs. That's chronic venous insufficiency in a nutshell. Poor return of venous blood from the legs, leading to swollen ankles, aching, skin changes, and in severe cases, ulcers. The most important players in this drama are the venous valves and the calf muscle pump. So, where does running fit into all of this? Is it a hero that strengthens the calf pump and protects your veins, or a villain that increases pressure and damages valves? Spoiler, it's complicated, and the nuance is what we're here for. Let's make this visual picture: a garden hose carrying water up a hill. Inside the hose are tiny flaps, valves, that stop the water falling back when the pump stops. Now imagine those flaps get floppy, or the pump gets weak, water pools, pressure rises, and the hose bulges. That's your leg medically. CVI describes symptoms and signs caused by venous hypertension or high pressure inside the leg. Veins causes include failure of valves in superficial or deep veins, obstruction from previous clots, post-thrombotic changes, and poor calf muscle pump function. Clinically, you'll see varicose veins, swelling, skin discoloration, itching, heaviness, and in advanced cases, venous ulcers. Important risk factors: increasing age, family history, female sex, obesity, pregnancy, prior deep vein thrombosis, and prolonged standing or sitting. How common is this? Different studies and definitions give different numbers, but varicose veins and chronic venous disease are extremely common, affecting millions worldwide. Some systematic reviews find prevalence estimates in the tens of percent in certain populations. For example, studies among healthcare workers reported prevalence around approximately 25% in a recent meta-analysis, and the condition becomes more frequent with age. Bottom line, it's common, and therefore relevant to a lot of runners and non-runners alike. Call it poetic if you want, but the calf muscle complex, gastrocnemius plus soleus, is often nicknamed the peripheral heart. It squeezes venous channels with each step and propels blood upward every time your foot hits the ground and your calf contracts. Venous blood is forced out of the leg and valves close to prevent backflow. If the muscles are conditioned and contracting effectively, venous return improves. If they're weak, or you're standing still for long periods, blood pools. So anything that makes the calf pump stronger and more efficient: walking, cycling, targeted exercises, should help venous return. That's a major part of the theory behind exercise as prevention or treatment for CVI. That same physiology is why doctors have long recommended walking and ankle exercises for people with early venous disease or leg heaviness. Movement is literally the simplest, most natural venous pump aid we have. Now the study-by-study truth. Several types of research address this question: mechanistic and physiologic studies that measure calf pump performance before or after training, small clinical trials testing exercise programs in people with CVI, observational studies comparing rates of venous disease among active versus sedentary people, expert guidance, and clinical reviews synthesizing the evidence. Here's the bottom line evidence summary you need to know. Number 1. Structured exercise improves calf pump function. Randomized and controlled training programs, calf-focused exercise, resistance, and aerobic training have been shown to improve calf pump action, ankle range of motion, and some symptoms in people with CVI. This is physiologic and clinically meaningful. Stronger pump, better venous emptying. Number 2. Systematic reviews find exercise can reduce symptoms, but the trials are small and heterogeneous. The most rigorous summaries, including a Cochrane-style update, conclude exercise programs may reduce symptoms and improve venous blood return in non-ulcerated CVI. But the evidence base is limited. Small sample sizes, different exercise types and intensities, and short follow-up in many trials, so exercise looks helpful. But the confidence in exactly how much and which exercise is best is still moderate. Number 3. Walking and low to moderate intensity aerobic activity are consistently recommended in clinical practice. NHS and vascular clinic guidance commonly list walking, cycling, swimming, and even running among helpful activities because they stimulate that calf pump and improve circulation overall. Most vascular surgeons and phlebologists advocate activity as part of conservative care. Number 4. Running specifically, it's not a clean yes or no. Running increases calf pump activation, good, and it improves cardiovascular fitness and body composition, good, but because running is high impact and sometimes raises intra-abdominal and intrathoracic pressures briefly. Some clinicians caution that very intense or heavy resistance exercise could transiently increase venous pressure or aggravate already dilated veins. Observationally, exercise appears protective overall, but people with existing symptomatic varicose veins may feel more swelling or discomfort after hard runs, in which case moderation, recovery, or alternative low-impact training may be better. In short, running likely helps in prevention via improved calf pump and weight control, but may worsen symptoms in people who already have advanced superficial venous disease. Depending on the individual, those are the big claims. I'll repeat the central practical sentence: exercise, including walking and other aerobic activities, helps venous return and can reduce symptoms. Running is usually beneficial but may cause more swelling or discomfort in people with existing varicose veins, so individualization matters. Let's unpack exactly how a run helps your veins. Number 1. Frequent calf contractions. Each stride is a pump stroke, more steps per minute, and a stronger calf means more effective venous emptying that reduces the time blood spends pooled in superficial veins. Number 2. Improved overall fitness and body composition, less abdominal fat, lower BMI, and better fitness, reduce mechanical and inflammatory stresses on the venous system. Obesity is a well-established risk factor for CVI, so weight control matters. Number 3. Better endothelial and microvascular health. Regular aerobic exercise improves small vessel function and reduces inflammatory mediators that may contribute to venous disease progression, though this is more indirect and less well proven specifically in venous disease compared to arteries. Still, a healthier microcirculation helps. Number 4. Increased ankle range of motion and neuromuscular coordination. Healthy ankle mobility ensures full CLF pump function. Running and targeted exercises improve that mobility. Put together, regular running is like a training program for your calves and for your venous circulation. The more efficient the pump, the less backflow and pooling. Medicine rarely has always or never, and this is one of those gray zones. If you already have larger, bulging varicose veins or advanced CVI, a hard, long run may make your legs feel heavier, more swollen, or painful afterwards. Why? Running raises venous return demand when the valves are incompetent and veins are dilated. The increased flow can actually distend the surface veins and increase symptoms in the short term. High-impact surfaces, hard pavement, and heavy eccentric loading can cause microtrauma and local inflammation if you already have significant valvular reflux. The mechanical stress of heavy exertion can make the symptomatic threshold more noticeable. Clinical advice therefore often says if running makes symptoms worse, reduce intensity, shorten duration, switch to low-impact cross-training, cycling, swimming, and use compression, but don't stop moving altogether. The benefits of movement usually outweigh the short term symptom flare. A practical rule of thumb used by many clinicians: if a run leaves your legs much more swollen and painful the next day, reduce the load and speak with a vein specialist. Persistent worsening is a red flag. We'll summarize the best interventional evidence, small randomized trials, and controlled studies of exercise training in people with non-ulcerated CVI show improvements in calf pump function, ankle mobility, and some symptom measures compared with control groups that did not exercise, effects on heart endpoints, ulcer healing, long-term progression. Have less robust data. Sample sizes are small and follow-up shorter. Cochrane-style review update concluded that exercise may be useful to reduce symptoms and improve venous return in non-ulcerated CVI, but emphasized the limited quantity and quality of trials, so the signal is positive. But we need larger standardized trials to define the optimal type or duration or intensity. Translation for real life: the best available trials support exercise as a conservative therapy for CVI. The evidence is not the same as a pill that cures everyone, it's more like a lifestyle therapy, with physiologic benefits that translate to symptomatic relief in many patients. A critical distinction: prevention for healthy people with no or minimal venous signs. Running, as part of a regular active lifestyle, with weak control, is likely protective because it strengthens the calf pump and reduces obesity-related risk. Running is one useful preventive toolkit item among others. Avoid prolonged static standing. Maintain healthy weight. Avoid smoking. Treatment for people who already have clinically significant CVI pain, edema, skin changes, ulcers. Running should be part of a multidisciplinary plan but may need modification, in particular supervised exercise programs focusing on calf strengthening, walking, and graduated return to running can help, sometimes combined with compression therapy. Severe anatomic problems, severe reflux or obstruction, may need interventional procedures, endovenous ablation, sclerotherapy, vein stripping in rare cases, in addition to exercise. So, running is a great preventive tool and a potentially helpful therapeutic adjunct, but it's seldom a standalone cure when structural venous disease exists. Graduated compression stockings have long been prescribed for symptomatic venous disease. They work by externally narrowing the veins, improving venous emptying, and reducing edema and pain for active people. Athletic compression socks are a popular option. What does the evidence say specifically for runners? A study of healthy amateur runners showed that graduated compression stockings can influence lower limb hemodynamics during running. They can assist the calf pump and reduce venous pooling. Athletic compression is also associated with reduced post-exercise soreness in some studies, but the performance benefit isn't clear for people with symptomatic varicose veins. Compression reduces symptoms and swelling and is a cornerstone of conservative management. Practical takeaway: if you have varicose veins or significant symptoms, wearing graded compression during runs and in the day can reduce swelling and discomfort. If you're asymptomatic, compression is optional. Some runners like the feel and recovery benefit, others don't. Important: compression should be properly fitted to. Tight or poorly applied stockings can cause problems. Talk to a clinician or fitter if you're buying compression for medical reasons. If you want to use running to help prevent venous disease, or you already have mild disease and want to run smart, here's a clinically informed, step-by-step plan. Number 1. Baseline check. If you have visible varicose veins, leg swelling, skin discoloration, wounds, or a prior DVT, see a vascular specialist before starting an intense running program. They'll likely recommend ultrasound, duplex, to characterize reflux and decide if interventional therapy is needed. This is not optional in advanced disease. Number 2. Start with walking and calf exercises. Begin with 15 to 30 minutes of brisk walking daily, plus specific calf strengthening moves: heel raises, 3 sets of 12 to 15, toe raises, ankle pumps, flex-point cycles, and seated calf raises. These improve muscle conditioning and ankle mobility. The physiologic studies showing improved calf pump function use such focused programs. Number 3. Progress gradually to running. Use a walk-run progression. Example: week 1 to 2 minute run or 3 to 4 minute walk to 6 repeats. Increase running segments over 6 to 8 weeks. Pay attention to symptoms: swelling, heaviness if symptoms flares. Step back. This approach reduces mechanical shock and conditions the calf pump. Number 4. Surface and shoes. Prefer softer surfaces or well-cushioned shoes if you have leg swelling or Discomfort. Hard concrete increases impact and local stress. Number 5. Compression. If you have symptomatic varicose veins, wear graded compression socks during and after runs. Many runners use 20 to 30 mm of mercury compression for symptom management if you're asymptomatic. Use as desired. Number 6. Cross-train and strength train at cycling, swimming, and targeted lower limb resistance training. Calf raises, eccentric calf work, to build muscle without constant high impact. Number 7. Recovery and elevation after runs. Elevate your legs for 10 to 20 minutes and hydrate. Elevation helps venous drainage and reduces post-exercise pulling. Number 8. Weight control and lifestyle. Maintain a healthy BMI. Avoid prolonged static standing when possible, and manage pregnancies and hormone-related risk factors with your physician. Number 9. When to stop and see a doctor. New or worsening swelling, skin discoloration, open wounds, or severe pain. Stop and see a clinician. Also see a vascular specialist if running leaves you consistently more symptomatic. This plan synthesizes physiology, trial evidence, and standard clinical guidance. It's pragmatic and safe for most people, but remember, individual variation is real. Let's look at two composite cases based on clinical patterns I've read about in vascular literature and clinic guidance. Caser: Rachel, 42, teacher, runner. She runs 30 to 40 kilometers per week. BMI 23. No family history. She noticed mild spider veins at 38 but no pain. She kept running. Added calf exercises and occasional compression for long runs, and at 40 to her veins cause cosmetic concern only. She focuses on weight control and mobility, and ultrasound shows minimal reflux. Verdict: running probably helped prevent progression. Case B: Mark, 55, warehouse worker, long history of standing. Obese, BMI 33. Developed large varicose veins and swelling. He continued to run to lose weight but found more swelling after runs. After vascular assessment, he had significant superficial reflux requiring endovenous ablation after intervention plus supervised exercise and compression. His symptoms improved and he returned to modified running. Verdict: running alone couldn't reverse structural valve failure. It helped with fitness but needed combined management. Why these vignettes matter: they show how running interacts with the underlying anatomy and risk factors. If the valves are mostly intact and you're fit, running helps. If there's major structural disease or long-standing risk accumulation, running alone won't fix the valves, but it's still beneficial as part of a multi-pronged approach. For those with substantial valvular reflux or symptomatic varicosities, interventions exist, and they're often paired with exercise afterward. Endovenous thermal ablation, radiofrequency or laser, minimally invasive, performed under local anesthesia. Targets the incompetent saphenous vein, frequently preferred for superficial truncal reflux. Ultrasound guide foam sclerotherapy, chemical ablation for smaller veins, phlebectomy, removal of bulging surface veins through tiny incisions, deep venous reconstruction or valve repair, rare. Reserved for complex post-thrombotic disease. Exercise and compression are still important after procedures to speed recovery and maintain calf pump conditioning. Current practice recommends early mobilization post-procedure, and many clinics explicitly recommend walking and avoid prolonged bed rest. Myth 1. Running causes varicose veins. Fact: there's no strong evidence that running causes varicose veins in people without underlying predisposition. On the contrary, regular movement is protective if you already have disease. Running may exacerbate symptoms occasionally, but it isn't the root cause. Myth 2. If I have varicose veins, I must stop all exercise. Fact: no, avoid only the activities that clearly worsen your symptoms. Many forms of exercise help. Walking, swimming, cycling, and properly managed running are usually fine and encouraged. Myth 3. Compression stockings are useless. Fact: quite the opposite. Compression reduces edema and symptoms and can be an effective conservative measure in symptomatic disease. The evidence supports their use, especially when combined with exercise. Clinical practice guidelines and major vascular reviews recommend conservative measures first for mild to moderate CVI: leg elevation, weight control, exercise, and compression exercise. Walking and supervised calf programs is part of conservative management and can improve symptoms and calf pump function. If symptoms are significant or anatomy amenable, offer endovenous interventions alongside conservative care. Individualized advice about high-intensity exercise like long-distance running. If symptoms worsen, consider compression, cross-training, or procedural options if needed. Which brings us to the bottom line answer: can regular running prevent chronic venous insufficiency? Yes, running, as part of an active lifestyle that strengthens the calf pump and helps control weight, likely reduces the risk of developing symptomatic venous disease. For many people, exercise improves venous return and calf pump function, the two major physiologic defenses against CVI. Can running make things worse? For people with pre-existing significant varicose veins or advanced CVI, high-intensity or very long runs may temporarily worsen swelling and discomfort. In these cases, modify training, use compression, or seek specialist assessment. Best approach: keep moving. Start with walking and calf exercises, progress sensibly to running. Use compression if symptomatic, cross-train, and get vascular assessment for persistent or severe symptoms. This is a no-nonsense, evidence-friendly, progressive program for people who want to use running to help venous health without overdoing it. Weeks 1 to 2: daily ankle pumps 3 x 30, heel raises 3 x 12, 20 to 30 minute brisk walking 5 times per week. Focus on full ankle dorsiflexion. Weeks 3 to 4, walk or jogging intervals 1 minute run or 3 minutes walk. 6 calf eccentrics 3 x 12 twice weekly. Compression socks optional. Weeks 5 to 8, increase run segments gradually, 2 to 5 minutes run, 1 to 2 minutes walk. Add cross-train day, cycling or pool. Maintain calf strength to time per week. Wear compression during long sessions if symptomatic. Weeks 9 to 12, continuous 20 to 40 minutes easy runs 3 times per week at conversational pace. 1 long slow run, if well tolerated. Ongoing strength and cross-train. If swelling or heaviness increases, drop intensity for a week and use compression after 12 weeks. Re-evaluate symptoms if swelling, skin changes, or wounds appear. Schedule vascular assessment. If not, maintain and progress gradually. This plan emulates the supervised, condensed training used in some calf pump rehabilitation trials that showed physiologic benefit. New unilateral leg swelling with pain increasing, persistent swelling, skin darkening, or ulceration. New spontaneous bleeding from varicose veins, symptoms not improving with conservative care. If any of these happen, get evaluated. Ultrasound is the standard diagnostic tool to check valve reflux and obstruction. Vein disease is one of those conditions where a small daily habit, walking or running, calf exercises, elevation, compression when needed, can have outsized lifetime benefits. Running is rarely the villain, and in prevention it is one of the best things you can do for your leg circulation, alongside weight control and avoiding long static periods. But it's not a magic bullet. Listen to your symptoms and get evaluated if things worsen. If you like this deep dive, smash that like button. Share this with a friend who's been telling you their legs ache after a long run.